Hello and welcome everyone. Thank you for being here with us today to discuss our treatment of tenosynovial giant cell tumor, TGCT, has evolved over the last years and how can we change our clinical practice to maximize what we have available. Today I am here with my dear colleague, Dr. Vino Ravi, medical oncologist from Andy Anderson Cancer Center in Houston. And I am Silvia Stacchiotti, medical oncologist as well, from the National Cancer Institute in Milano, Italy. We really would like to thank Peerview for providing us this session and EMD Serrano for supporting with an educational grant this initiative, this symposium. If you haven't already, please complete the pre-event survey and look out for additional polling during the presentation. Please try to submit all the questions you have, and we will try to answer them at the end during the Q&A session. And for those in the room, thanks for being here. Please use your personal device to scan the QR code, while for those connected virtually, you can respond to polls on your screen and enter your question in the chat window. So this is the QR code for the question and answer. While here is another, sorry, maybe I was too fast. Please, you can take your time to scan it. And this is the second QR code to download the slide after the presentation on the web if you want. So, Vino, what are we here for today?
Okay, so learning objectives for today. Today we hope to introduce and reinforce that surgery remains the mainstay of treatment for postoperative recurrence in diffuse tenosynovial giant cell tumor. Systemic treatment options such as CSF1R receptor inhibitors are available for patients who are not amenable to surgery and have recurrent or progressive disease. And multidisciplinary cancer care teams should be prepared to collaborate to identify patients who are best suited for drug therapy and manage the practical aspects of care delivery, including management of side effects. So I'm going to hand back to Dr. Stacchiotti to discuss the preliminary data around the biology of the disease and the new agents that have come into practice.
So TGCT is a rare mesenchymal tumor that involves the joint and the tendon sheaths and can be subdivided into two different subgroups based on pathology and radiology. Indeed, we have localized TGCT. They are usually small, well circumscribed, and they can usually be cured with complete surgical resection. And then we have the diffuse type TGCT that instead are usually present as a large multiple masses and are locally aggressive. In none of the two cases, the disease has the potential for metastasizing. So we are talking of a locally aggressive disease. By morphology, both nodular and diffuse type TGCT looks the same, with the exception of the borders that are more invasive for the diffuse type TGCT. And the tumor is made by two different kinds of cells. We have the true tumor cells, that is a spindle cell, usually not very much represented in the tumor, while the majority of the cells that we found are macrophage-like cells that can be mono or multi-nucleated cells. The second type of cells is an inflammatory component that is attracted in the tumor as a consequence of the biology of the tumor itself that we will discuss later. Diffuse type TGCT, that in the past was also called pigmented villonodular synovitis due to the color of the tumor at the time you see the macroscopic sample, typically affects larger joints. The knee is the more common site. It usually affects young patients. The first diagnosis is often made between 30 and 40 years. Can be very much symptomatic with inflammatory-like features, swelling, pain, and functional limitation, and often is diagnosed late, after more, but even more than a year from the symptoms onset. MRI is the radiologic assessment of choice, even though the orthopedic surgeon might ask for X-ray and a CT scan to see some of the effect of the tumor, like the erosion of the joint surfaces. And as anticipated before by Dr. Ravi, surgery has to be considered the standard of care in all cases, particularly for nodular type TGCT that more often get cured with the surgery. For diffuse type, surgery still represents the standard of care. However, the recurrence rate is high, more than 50% after complete surgical resection. And the reason for recurrence, the risk factor are the diffuse type, the tumor sites, prior tumor relapse, the local extent, the surgical technique, even though data are not conclusive, usually open surgery is considered associated to a lower risk of recurrence, and treatment outside expert center. Considering the high risk, high proportion of patients who recur locally, today we have to say to think that surgery alone is not the only treatment that we have for patients, and TGCT patient, especially at the time of relapse, should be discussed into the multidisciplinary tumor board and considered also for alternative approaches, included in particular systemic treatment. And here you can scan the code and answer the question. As I said before, TGCT is characterized by a peculiar biological mechanism that is responsible for tumor growth. This is the CSF1R overexpression that is mostly dependent on the presence of a fusion gene, but not only, and is responsible for the hyperproduction of CSF1 that recruits within the tumor the macrophage-like cells that are responsible for all the inflammatory features that affect the patient. Of course, the presence of this mechanism is the basis for the use of systemic treatment. How do we treat TGCT? Here is nicely summarized. For a patient with a new diagnosis, if the patient is not symptomatic, active surveillance can be considered the treatment of choice. If the patient is symptomatic and the tumor can be resected completely without any morbidity, surgery has to be considered the standard treatment. When instead the patient cannot undergo a complete surgical resection, or surgery is related to a high risk for morbidity, the patient should be discussed for a systemic treatment, again, only for symptomatic patients. Then, what treatment? Today we have MCSF1R inhibitors that can be started, and based on the response we have, surgery can be reconsidered. So in case of treatment achieving a response after some time, and the duration is not yet well defined, the options are to continue with the treatment, to reconsider surgery, or to stop the treatment and consider active surveillance. Unfortunately, many patients with TGCT are initially seen by different kinds of specialties, meaning rheumatologist, sport medicine doctor, general orthopedic surgeon. Ideally, the patient should be treated as a disease onset in a center with expertise in the disease, together by the orthopedic surgical oncologist and the medical oncologist. These, as shown retrospectively by different studies, correspond to a higher chance for a cure. And again, here we have questions for you to answer. So now let's go through a few clinical cases to discuss together how we can make the best use of the systemic agents that luckily were developed during the last years. Let's start with the case of a 34-year-old guy who was initially diagnosed diffuse type TGCT at the age of 22. The tumor affected the knee. Here you see the pathologic picture with the giant cells typical of the disease. The differential diagnosis is sometimes critical, but usually can be easily done by an expert sarcoma pathologist. After the first and the second surgery, the patient relapsed again and started suffering of symptoms. This is the relapse. Due to the second relapse, surgery was excluded. And so what treatment want we to consider for this patient? Before discussing the case, let's look together to the literature. So according to the NCCN guidelines, we have different drugs available. We have MCSF1R selective inhibitors, pexidartinib and vinceltinib available in the US for frontline treatment of locally advanced, unresectable, and symptomatic TGCT patients. And we also have multi-target tyrosine kinase inhibitor, imatinib and nilotinib, that were developed before. Imatinib was investigated only retrospectively, and nilotinib was investigated in a phase 2 study with most patients achieving tumor stability. The first drug to be studied among the MCSF1R inhibitor was pexidartinib within the ENLIVEN trial. This was a phase 3 multicentric international prospective study where pexidartinib were confronted with a placebo in a patient population of adult TGCT with locally advanced unresectable tumor and symptomatic disease. The primary endpoint of the study was the overall response rate at 25 weeks. After 25 weeks, for those patients on placebo, there was the chance to be crossover to pexidartinib. Together with the overall response rate by RECIST, many other quality of life and functional endpoints were incorporated, and this is very important in a disease where our goal is the quality of life of the patient, as none of the MCSF1R inhibitor we have can eradicate the disease. This study design is replicated in all the other studies that were conducted in this tumor type, and so we will not go through again the study design. So the ENLIVEN study proved the activity of pexidartinib with a almost 40%, 39% overall response rate by RECIST at week 25. As you can see from here, placebo didn't achieve any clinically meaningful tumor reduction. At longer follow-up, the lower graph, the proportion of patients achieving a major response increased. What is also, this was the basis for the FDA approval. This was the first drug approved by the FDA for this tumor, for again, patients with symptomatic, locally aggressive, unresectable disease. And what is even more important to me than RECIST is the improvement in the PROs, the function, the pain, because as said before, what is relevant to this patient is the improvement in symptoms. Basically, all the PROs that were used showed an improvement in pain and function. As I said before, the amount of patients achieving a almost complete or a complete response with pexidartinib increased over time. And pexidartinib was followed by the development of another drug. This is a different mechanism of action, is a switch pocket tyrosine kinase inhibitor. The drug is called vinseltinib. The same study design, again, the drug was confronted to placebo. Vinseltinib in this study was given orally at the dose of 30 milligram twice per week, with the primary endpoint being again overall response rate at week 35. And also this second study called MOTION confirmed the activity of this class of agent with an overall response rate of 40% at week 25. The functional and PROs assessments were all consistent with the RESIST response, so patients benefited in terms of pain and quality of life. And what is important is also the phase 1-2 study of vinseltinib that was conducted prior to phase 3 that showed that this drug can work also in patients already pretreated with another MCSF1R inhibitor. So the cross-resistance is currently not observed with this class of compound. For patients already pretreated, the overall response rate was similar, meaning 37% instead of 40%. So going back to this patient, the patient received imatinib. And this because I was treated in Italy, and at the time he needed the treatment. None of the other selective MCS1R inhibitor was available, and he achieved an improvement in the symptoms. Resist were almost not there. I mean, the disease remained stable, and after a while, the patient decided to go for a new debulking surgery. Unfortunately, after some time, he started suffering again of a symptomatic progression. And again, we had no MCSF1R inhibitor to offer to the patient, and he entered another study with a multi-tyrosine kinase inhibitor called surufatinib, again with a symptomatic improvement. And this to show that, as I said before, moving from one drug to another can still bring benefit to patients. In this case, we had some kind of minor tumor shrinkage, but the patient had to stop treatment due to toxicity, and in this case, it was skin toxicity. We will get back to this later. And so he decided to stop the treatment and to consider again surgery. Unfortunately, after a while, he had a new radiologic and symptomatic progression that you can see here. So I want to ask to Vino, what would you consider here for a patient already treated with imatinib and surufatinib, with now maybe some new selective drug available?
Yeah, the answer to that question really depends on which part of the world you're in and what agents you have access to. But here in the US, at least at this current moment in time, we would consider the patient for treatment with more selective CSF1 receptor inhibitors such as vimseltinib or pexidartinib, which are both approved for this particular indication where a multi-recurrent patient is presenting with symptomatic and radiologic progression.
Indeed, at the time the patient needed to start a new treatment, the study on vinseltinib was open, so it was put on study. And he started vinseltinib 30 milligram twice per week as per protocol, and he got a rapid tumor regression and symptomatic improvement, as you can see here in 3 months of time. Unfortunately, also side effects occurred. So, in general, MCSF1R inhibitors are well tolerated, meaning that the most common side effects are periorbital edema, face edema, and this is due to the mechanism of action of the drug, and they can suffer of rash and increase of transaminase. In general, most side effects with vinseltinib are grade 1 or 2. They regress upon treatment discontinuation, and luckily no severe liver toxicity was observed with this agent. And transaminase usually get back to the normal value when we discontinue the drug. Another side effect that can disturb the patient is whitening of the hair, especially for male. This is my experience. So how would you handle this patient? And also, how do you manage CPK elevation? That is a very common test we observe in this patient. I don't know if I can call it side effect or not.
Yeah, that's a great segue. Actually, it's more of a pharmacodynamic endpoint for most of us who treat this disease, because we regard that as a feature of the drug actually working. This elevation in CPK results from the liver Kupffer cells not being able to clear the CPK, which is not because of muscle destruction or rhabdomyolysis like in the traditional sense. So it's got nothing to do with muscle injury. It's just a pharmacodynamic marker telling you that the drug is working. You usually don't particularly react to it other than watching renal function and making sure some other cause unrelated to the drug is not operating.
And may I ask you maybe a more challenging question? So outside the protocols that were mandating us to look at CPK, would you in your, or do you in your regular daily life ask for a CPK test in your patient when they receive this kind of drug or not?
We do monitor it, but it needs to be contextually interpreted to make sure that it's only because of the drug-related decreased clearance of CPK and not because of any other specific cause. And we're still early in the experience with all of these drug classes, so I think it's pretty responsible to continue to monitor and make sure that is indeed the case. It's not isolated to CPK. All of the enzymes, AST, amylase, lipase, these are all getting elevated because of the decreased clearance by the Kupffer cells. So something to monitor on treatment, but it's important to understand the underlying mechanism.
Thank you. And for skin rash, what do you do?
Yeah, so skin rash, it's interesting because these result from proteoglycan deposition in the extracellular matrix, which macrophages play a really important role in clearing and modulating, which gets inhibited. So that's what is causing the skin toxicity. So it's very responsive to the degree of inhibition you produce on the macrophages, and therefore very responsive to dose reduction. So if you're getting good clinical response, you can reduce the dose and thereby still allowing some of the skin level macrophage function, and the rash will get better. You can also use corticosteroids quite effectively as part of any TKI-mediated skin toxicity.
Yeah, this may be more for the acute phase that is not common, but sometimes can really bother very much patient. So going back to our, before there is another question for you to answer. Okay, so let's say that our patient cannot continue the treatment with the vinceltinib. We will get back to him at the very end. What about pexidartinib? Would you consider that drug? Do you see a different toxicity profile? What are your considerations, about toxicity and balance benefit and toxicity?
No, I think one of the major advantages of having multiple drugs available is exactly that. I think it's very reasonable with proper monitoring to consider pexidartinib as well, especially if the toxicity is somewhat selective. For example, edema in the periorbital context is pretty common with vimseltinib, and you wanted to use a different agent. You can either deal with it by dose reductions or choosing an alternative agent that doesn't inhibit as readily, and thereby taking advantage of a different side effect profile of a different drug, and switching around will allow you to find what is best for any given particular patient.
However, unfortunately, pexidartinib showed also a potential, although very rare, life-threatening risk of toxicity to the liver, and this prevented the approval of the drug in Europe, for example, where pexidartinib is not available, while the drug, as I said before, was approved in the US, such as vinceltinib. And in the US, you have a monitoring plan that is in place, right?
That's right. So hepatic toxicity is certainly something that you have to be super careful about whenever there is pexidartinib use. This is particularly because you're managing a condition that's non-lethal with a treatment that could potentially end up in a lethal complication. It's not common, it's pretty rare, but monitoring is super critical. So what you're looking for is the cholestatic toxicity picture with pexidartinib. There is a schedule for monitoring the liver enzymes as shown here. So you want to get baseline liver function tests and then monitor it weekly for the first 2 months, every 2 weeks in the 3rd month, and then every 3 months thereafter. This is just for detection. The moment you detect any particular abnormality, I usually switch over to weekly monitoring because these are only indicated in patients where you don't see any abnormality. You follow this schedule. So more frequent monitoring if there is any liver toxicity that you observe, and you need to reduce dose in 125 milligram increments.
So going back to our patient, we were in Europe, as I said, pexidartinib was not available. Patient was in the protocol that allowed us for a dose reduction. And it did, when the acute phase of the skin toxicity soared, the patient went back to treatment with a lower dose, 20 milligram twice per week. And indeed, the skin rash didn't come back, and the patient benefited from the drug with a good tolerance that is confirmed even now. So basically, this patient is on treatment for more than 3 years. And we also rediscussed the case with the surgeon. They commented that the surgery is not an option because of also the destruction of the joint. So the decision with Brian is to continue on treatment at least until we can prescribe the drug in Italy. The drug is approved by EMA, but not yet prescribable everywhere. And again, a question. So now I will pass again to Dr. Ravi, who will discuss another drug.
Thank you, Sylvia. So after talking about the agents that are currently available in the market, the next drug we are going to talk about are the emerging agents in the context of a clinical case. So this is a 24-year-old with diffuse TGCT referred to us in MedOnc by the orthopedic oncologist. Patient's initial diagnosis at age 17 with her first surgery being an arthroscopic synovectomy. Later developing a recurrence, went on to get another open procedure, and then followed by additional recurrence, thereby prompting the consultation. So what kind of next steps would we consider for Amy in addition to what FDA-approved agents that we already discussed, which we went over the last few minutes. So pimicotinib was an agent which was at that time available to us through a phase 3 clinical trial. It's an oral switch control TKI that selectively and potently inhibits CSF1 receptor. So we chose to actually enroll this patient into the phase 3 maneuver study. The study design is identical to the previous designs, especially vimseltinib, where there was a 2:1 randomization in the first part or the first 6 months of the study. The key things to remember about this study, this was global, so there was half the patients were enrolled in China, remainder across the rest of the world. So 23 sites in China, 7 in Europe, and 10 in North America. Patients went through 6 months of therapy, followed by an open label phase where everybody was on drug. So pimicotinib was associated with substantial reduction in tumor size. You can see that 92.1% of patients in the pimicotinib group really did have a reduction in tumor size, pretty impressive waterfall plot there. And the overall response rate is 54%, which shows robust activity at 6-month time point compared to placebo, which was at 3.2%. I want to just remind that all of the drugs are active. The pimicotinib seems to actually get to a response rate criteria at 6 months a little faster than some of the other agents, which may also be related to the type of patients who were enrolled into the study, which were symptomatic, highly symptomatic patients who are probably best suited for this particular therapy. Pimicotinib also showed improvements in range of motion, worse pain, worse stiffness, and promise questionnaires looking at function and quality of life. This is probably more important than the response data at a practical context for the patient and for us clinicians. So regarding side effects associated with pimicotinib, dose reductions were observed only in about 8% of the patients, so extremely well tolerated, and interruptions were like 1.6%, which is pretty impressive for any oncologist because we do run into these problems way more frequently with other drugs. So pretty well tolerated drug. And here are the side effects. You'll notice here that pruritus occurs in about 52.4%, which uniquely is more than the other drugs within this drug class. Edema is typically, especially no grade 3-4 edema was observed, so the edema is a little better than vimseltinib, again pointing to the relative differences between the agents when you're picking based on patient preferences. Rash, skin toxicity is also observed in about 35% of patients. Fatigue, nausea, all common to drugs in this drug class. There was no evidence of any hair or skin hypopigmentation, a side effect that is unique to pexidartinib because of its interaction with c-KIT and SCF in hair pigmentation, which is not seen with this particular agent. 14.3% of patients did develop hypertension, but grade 3 was only 3.2%. Again, on the right panel, you see all of the blood parameters that are increased because of decreased clearance by the liver Kupffer cells. Again, also a reminder, since we are in the early phases with this drug class, always to continue to have the same vigilance for any obstructive pattern in patients at all times. This was not observed with pimicotinib, so it seems like it's a pretty safe entity, but we're still less than 1,000 patients on the drug, so I always advise caution as we move forward in terms of vigilance. This slide shows, echoes the same thing that Sylvia was showing about pexidartinib. As time moves on, the responses get deeper. The panel on the left shows you the 6-month analysis, and the panel on the right is the 14.3 months analysis. And you'll see that the best overall response is now 76% over the 52% that was observed at 6 months. So if you don't like the response you see, keep the patient on drug, and you can harvest deeper responses as time moves on. So coming back to our patient, because of clear functional limitations, we decided to enroll the patient onto a study with pimicotinib. I'd like to emphasize this is a point where, from a counseling standpoint, you want to discuss all of the agents, all of their side effects with the patient, and with the patient's involvement, help understand what their goals are, what things are on their time horizon, keeping in mind that this is a chronic illness in a 24-year-old. She likely will have intermittent therapy throughout the course of her life, so involving her in the decision-making is a pretty important step. So patient was initiated on pimicotinib at 50 milligrams through the clinical trial, and at this particular patient, we did not observe any of the side effects that we initially talked about in the label. However, the management of the side effects for side effects such as edema or rash is the same as the other drugs in this particular category, where you would hold the drug for resolution of the side effects, reintroduce at a lower dose as needed based on the package insert recommendations. Does this, I'd like to ask Sylvia, how does this differ from vimseltinib or pexidartinib, at least in the side effect profile in the practical use of, is this side effects of rash and edema, is it resonant of what we see with vimseltinib?
I have to say that our experience in Europe, especially with pexidartinib, is lower than the one you have because we had access to the drug only in the study. So I believe that different drugs can be a little bit different in terms of the side effects. Not only liver toxicity that, as we said, is different, is higher with Pexi, but also, for example, edema and whitening of the hair. And I believe that as those are very young patients with a totally active life and can suffer on the long term from these side effects, having the chance to access different drugs can surely be relevant to them. And also the schedule is different. With vimseltinib, we have twice per week administration, while with pimicotinib is daily administration. This can also be better or not better appreciated by the patient. Some patients prefer to have a regular assumption of the drug, and this sometimes can also come with a higher toxicity level. So what I mean is they are similar but not superimposable, and I believe it is a shared decision with the patient that at the end is the way to decide. Of course, what is available mandate the discussion.
Absolutely. Availability. We hope that all the options become available to patients globally soon. So this was the baseline imaging for Amy at enrollment. This is at cycle 4 and at cycle 7 at a point where the patient was ready to cross over to the open label portion. So the open label portion, patient continued, for reference, the panel on the left shows the baseline scans again. Patient did not regrow before the open label portion of it. She just nicely transitioned into the open label portion. And in January of 2025, the last month that the patient was on drug, the MRI is shown there on the panel on the right, which is when she actually developed a ocular side effect of raised intraocular pressure. She has a family history of multiple family members developing decreased vision because of raised IOP. I don't think this is directly related to drug, but we did not want to continue drug in a setting where there was a substantial medical concomitant illness that could be affected by how fluid dynamics were happening within the eye. So we chose to stop the drug on the basis of this particular side effect. So the key important thing that happened, the stopping of the drug happened in February of last year, and then patient went on to surgery, which I wanted to kind of introduce as a method of really transitioning some patients who are not candidates to continue therapy can be reconsidered for surgical intervention as a definitive procedure to keep them off drug for the longer term. So in June of last year, she underwent a radical resection and continues to, including a joint replacement, and continues to remain without any evidence of recurrence. So you can go ahead and scan this QR code for a follow-up poll on managing a patient on pimicotinib. So regarding conclusion and final take-home points, localized TGCT and diffuse TGCT are clinically distinct entities. There is a much higher risk for diffuse TGCT for recurrence than in localized TGCT, which is primarily managed surgically. Surgery remains mainstay of treatment, but postoperative recurrence in diffuse TGCT is widespread, greater than even 50%. So understanding who those patients are is important. And including medical therapy as part of their multidisciplinary care may be indicated in patients with symptomatic disease that is not amenable to surgery. And with the advent of systemic therapy, a team-based approach may be helpful in improving outcomes. I believe we have some questions.
Yeah. So while you have to scan again the QR code, I think we have 5 minutes for the questions. So I want to first thank we know, and also all those who raised some of the questions. And we can start by the question raised by Dr. Weiss, who is asking us as a surgeon, when medical oncologists do like to be involved in the management of a patient with TGCT. He's also asking how fast skin rash solved. So I don't know, if you want to answer one, maybe the first, and then I can go to the second.
Sure. So I think that's an excellent question. When do you refer to med-onc? If you see where the road is eventually going to lead to, it's always a good idea to involve the medical oncologist early. Because what I find is that when we introduce all of these side effects to a young patient who it's pretty overwhelming for them. So hearing that, and especially at a time where the symptoms are not super heavy, is helpful for the patient to understand what options are available. And as the symptoms get more significant, they begin to start weighing the side effects of treatment that they heard and potentially thinking about taking on drug therapy. So seeing them early is what I prefer to do. I don't know, Sylvia, how you...
Yeah, I agree. Maybe what is also important to say is first that we still miss a study that proves the potential role of this class of compound as preoperative treatment. So this is not to be considered a standard. It's different to have a patient with a locally advanced unresectable disease that after a great response can be rediscussed for surgery than having a resectable patient in which we want to improve surgery. And so, because we still miss this data. On the other side, I believe that the interaction with the orthopedic surgeon should be constant, even during the treatment. And this is because patient can develop other problems like worsening of the osteoarthritis, worsening of the pain that is not necessarily related to a disease progression. So I believe that the interaction should be, let's say, constant. Also, to ensure the medical oncologist that it's worth continuing the systemic treatment and not considering surgery.
Yeah, I would agree. And Dr. Weiss, your question about the skin manifestations, always think about these side effects in the context of CSF1 inhibition in macrophages. So sometimes it can take a long time to resolve. So CPK elevation sometimes the median time is like sometimes 15 weeks for it to resolve. So don't expect changes very quickly. It will come around as you ease up on the CSF1 receptor inhibition, and it'll resolve over time, but it is not instantaneous. So one thing to kind of remember. It also depends on the half-life of the drug. So emactuzumab, which is injectable and sticks around for a longer time, will take a much longer time horizon for symptom to resolve. But it also has the advantage that the effects or efficacy of the drug also lasts a lot longer past the last administration. So it cuts both ways. So it really depends on the drug and the half-life of the drug and whether the macrophages are inhibited or not.
If we have some more time for other question, there is a question about MRI alone is enough or we need a biopsy to start a systemic treatment. For sure we need a biopsy. I think there are no doubt, even though radiology can be very, let's say, suggestive of a TGCT is not enough. There are still diseases that can be in differential diagnosis, like also, for example, synovial sarcoma, that is a totally different kind of tumor. While CSF1R or CSF1 detection is not needed for diagnosis, nor immunohistochemistry assessment, neither NGS or whatever else. And this is also because, as we said at the beginning, the amount of spindle through tumor cell is very little. So what you will see are more the inflammatory-like cell, and usually morphology is enough clear for the pathologist to confirm diagnosis. Then, another very, very relevant question, for how long you treat a patient with systemic treatment?
Yeah, sometimes the question there is how long time is left before Christmas or Thanksgiving when they don't want to be on drug. So it's really a discussion with the patient to determine at what point we can stop. We know from the studies that we have done that it is safe to stop and restart as symptoms get worse or We rarely ever go after radiographic progression. We really like to let symptoms kind of guide us, and it is totally safe to do that. Some patients, when they stop drug, their pain will return fairly quickly, and those are the ones where you will have to put them back on drug, maybe after their vacation is over or whatnot. Some will, they're not having side effects, may choose to even continue on drug. So it's very individualized and discussed with patients as we go.
Yeah, then we might probably say that as physicians and researchers, we would really like to have a discontinuation study at a certain point where we can try to answer in a better way this kind of question. For now, we only have the phase 4 study of pexidartinib, in which really a small amount of patients, less than 20, discontinue the treatment after many years, and this is a particular that we don't need to forget. And 50% of these patients progress during the 2 years after discontinuation, while 50% didn't. So meaning that some patients can be restarted with another drug, usually with a new response. Some other can stay off treatment. And this is also something we need to tell to our patients.
Yeah, absolutely, absolutely. There's a question regarding testing for CSF1 mutations, whether they have any value. Really, the therapeutic target is really on macrophages, and these are like normal cells with this CSF1 receptor. So it's very different sort of a concept than managing other neoplastic conditions where your target is on the tumor cell. Here we are actually inhibiting CSF1R on macrophages. So I don't think that there's a huge amount of value in looking at mutations on these macrophages. You will see changes that are not particularly clinically relevant. Sylvia had shown data earlier that in patients who had gone on one particular inhibitor going on to vimseltinib again, the response rates were fairly identical, 37% versus 40%. So it's pretty close. So it's pretty clear that when you reintroduce as well, there is no resistance. So it's safe to do this without switching around or looking at the mutational status of CSF1.
So I believe we went almost through all the questions we had, and we are also maybe a little bit out of time. So with this, I think we can conclude our meeting today. And again, we thank Purview, we thank MD Serrano. I thank you and all those who are here and are connected virtually for staying with us today.
Thank you, Sylvia. It's been a pleasure to be here. Thanks. Just as a reminder.